Good morning. I want to talk to you this morning about an effort that I've been engaged in now for almost 10 years to estimate the global burden of disease attributable to air pollution. Next slide, please. This is an ongoing effort. Well, actually, let me step back a second. The reason I think I am here is that we have evaluated as part of this effort much of the same evidence that is of interest to the Air Resources Board in their work, and there was some interest in seeing how we had done it and what we had concluded and made of it. This global burden of disease comparative risk assessment has been done periodically since the early 1990s under the aegis of the World Health Organization. The project is now based at a Gates-funded institute at the University of Washington called the Institute for Health Metrics and Evaluation. The purpose of the global burden of disease project is, and I go to the last bullet here, to produce disease, injury, and risk burden estimates for 1990 and 2005. This is the current update that I'm going to tell you about, using comparable methods for 21 regions of the world which collectively span the global population. And as part of this, air pollution is just a small part of this. Air pollution is one of more than 35 risk factors that will be, whose attributable burdens will be estimated in this project. And the goal is for each of those risk factors to estimate their attributable burdens using comparable methods so that at the end of the day, the estimates can be roughly compared in terms of their magnitude. Next slide. Last time this was done under the aegis of WHO was in 2002. It was in WHO's World Health Report, and the methods for the comparative risk assessment, including the methods we used for outdoor air pollution, are in a separate 2-volume collection. The most important message on this slide, you have it in your packet, are the websites. I would urge you to, if you want to learn more about this, the methodology and the results, please go there. I think you'll find it interesting. So, next slide. The last time we made these estimates for the year 2000, these are the results. Oops. These are the results, and what I'm showing you here on the x-axis is mortality, estimated attributable mortality in thousands. And this is within a total mortality envelope for the world of 55.86 million deaths in the year estimated by the project for the year 2000. And these are the 20 major risk factors, and the numbers of deaths that were attributed to them in the year 2000 in the project. And you can see that they are a very diverse group, and they include at the top end here tobacco, high cholesterol. We have low fruit and vegetable intake, and then we have among these four, I think what people would probably agree are environmental factors: unsafe water, sanitation, and hygiene, indoor smoke from solid fuels, urban air pollution, which is the estimate that our group was charged with making, and lead exposure at the bottom. And I want to draw your attention for a second to what we estimated for urban air pollution for the year 2000, and this was done using the results of the American Cancer Society study as reported in the 2002 paper that Arden Pope described to you earlier. We estimated roughly 800,000 deaths on a global scale in the year 2000 attributable to urban outdoor air pollution. This was in estimates made for cities over 100,000. And the color codes on the bars are of interest. Most of those deaths were occurring in lower mortality developing countries. That's like China and India. And we can contrast that with some of the results for some of the other environmental factors, unsafe water and indoor smoke, which had much larger attributable mortality burdens assigned to them in this effort. And most of those deaths were taking place in very poor countries. So, next slide. We're now redoing these estimates. I'm going to tell you about what we're going to do. and how we've used the evidence, how we're planning to use the evidence. We're going to include a lot more people, people in cities less than 100,000 and rural areas, and importantly, we're going to be using now what is a much more extensive evidence base from cohort studies, which has been very nicely described by Arden Pope earlier. We're going to use this much more extensive evidence base to estimate burden of disease attributable to outdoor air pollution. Next slide, please. A little bit on the GBD process. It begins in the sort of light-colored box on the left with a systematic review of the evidence on the health effects of each risk factor, in our case, air pollution. By systematic review, this means essentially applying established methods of meta-analysis to ascertain what work has been done, and to use that information to decide, first, whether there's evidence to support a causal association with a particular risk factor and exposure, in our case, air pollution, and then to try and use that information to derive a concentration response function for estimating burden of disease. And the key thing here is that all the risk factors do it the same. Okay, so all of the 35 risk factors, air pollution included, follow a methodology for doing this, and this ensures, we hope, at the end, that we can make the kinds of comparisons that I talked about on a couple of slides ago. And it's designed to try and eliminate special pleading on behalf of your favorite risk factor. And I think, in my experience, it's been fairly successful in doing that. The next step, which I've put a red box around, is very important, and this is actually where we are in the process now. And it involves extensive external peer review organized by the project overall of our reviews, or our systematic reviews, and of our proposals for concentration response functions. And there is a feedback loop from that process. So the work I'm going to describe to you today is going to be subject to external peer review and may change. I don't think it will change much, but it may change. And that is part of the process, and it's an important part of the process. Next slide. This is the outdoor air pollution expert group that is responsible for our work. I co-chair it with Ross Anderson. There are quite a number of people involved, in part because there's a whole sub-project involved in estimating what the annual average concentrations are of fine particles around the world, which is a very tricky business, since in many of the most important places there aren't any measurements. I'm not going to talk at length about how we're doing that, but I'd be glad to talk after the meeting with people about that if you're interested. I want to cite particularly in the work that I'm going to talk about in the next slide or two, the work of Rick Burnett at Health Canada, who's been responsible for developing our approach to concentration response function estimation for mortality. Next, here we are. Okay, just a couple of points about what we're doing, and in some ways contrasts with what's been done in other impact assessments of air pollution. We're focusing on cause-specific, not all-cause mortality. The reason for that is that the contribution of different causes of death to all natural cause mortality is different around the world. In sub-Saharan Africa, for example, there's high rates of maternal mortality, which we don't think is associated with air pollution, so we don't, and HIV, and we don't want to use an all-natural cause mortality result in that setting. So we focus on cause-specific, not all-cause mortality. We estimate attributable numbers of deaths. We also estimate an entity called disability-adjusted life years, which actually takes into account both effects on incidence and effects on mortality. It is the sum of the years that you live with a disability due to the disease and the years of life that you lose